Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with melanoma and other types of skin cancer with Dr. David Schoenfeld. Dr. Schoenfeld is an instructor of medicine and medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, David, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Sure, I'd love to. So I treat patients with skin cancers, mostly melanoma, and also kidney cancer. I'm also a physician scientist, so that means I conduct research both in the lab, so basic research related to these cancers, translational research, and also clinical trials, all in the hopes of coming up with better therapies and ways to treat our patients.
Fantastic. So let's maybe start off by talking about melanoma in general. Can you tell us a little bit more about what it is, how common it is, who gets affected, and so on?
Sure, I'd love to. So melanoma is a form of skin cancer. It's actually not the most common. Two other types of skin cancer, basal cell carcinoma and squamous cell carcinoma, are much more common. But melanoma is a more aggressive type of skin cancer, more prone to spread and more aggressive when it does spread. So it occurs at about 1% of all types of skin cancer as the estimate, although it's the fifth most common malignancy in the U.S. outside of the more common skin cancers that I just mentioned. So there's estimated to be about 100,000 cases of melanoma, or there are going to be about 100,000 cases of melanoma in the U.S. this year. And a little over 8,000 deaths from the disease, which is a rate that's coming down, but is still too high. So that's what we're working on. And then to go over a little bit about who gets melanoma, so it can happen to anyone, but there are known risk factors that increase the risks of someone getting melanoma. So if you have other types of skin cancer, we know you have an increased risk of getting it. If you've had melanoma before, you're certainly at risk for getting it again. If you have fairer skin, so more prone to freckling, sunburns, you have blonde or red hair, blue or green eyes, you're also more susceptible. And one of the major risk factors that's under people's control is exposure to UV light, so whether that's natural sunlight or through artificial lights such as tanning lights. Those are definitely risk factors as well for the development of melanoma.
Yeah. And so, as we think about as getting into the summer weather, we always like to remind people about things that they can do to protect themselves from the sun, because clearly everybody wants to be out in the warm weather. But can you talk a little bit about some of the preventative strategies that might help?
Yes, I'd love to, and I think that's very important, especially as you said, we get into the warm weather, and it is very nice to be out. And of course, we don't want people to not do that. That's one of the best parts of the summer and the nice weather. But we want people to do it as safely as possible. And we know, as I said before, that UV exposure is one of the major risk factors. So we encourage people just to do it safely and smartly. So if you can avoid being in the sun, so be somewhere and be in the shade, put up an umbrella. That's a great idea. But if you can't, then try to wear protective clothing, whether that's always having a shirt on, longer sleeve if possible. But as it's hot out, that may be more difficult. But also hats, wide brim hats are better. Sunglasses, and then for parts that are going to be exposed to the sun, using other protective measures such as SPF 30 or above sunscreen to really protect yourself. And also, if you can avoid it, being out of the sun during the hours we know where there's peak UV exposure, and that's generally considered 10 a.m. to 4 p.m. But if you can't, doing some of those other protective measures I just mentioned.
And so when we talk about sunscreen, you mentioned SPF 30. Can you tell us a little bit about what exactly that means and some of the things that we should be looking for on the SPF label? For example, sometimes we'll see it says UVA and UVB. Is that important or?
Yes, yeah, that's very important. I think you want to have broad spectrum protection from UV light, and that includes UVA and UVB. Most sunscreens that you'll find available that you'll be able to purchase in a typical store will cover that, but you want to check to make sure. And then SPF stands for sun protective factor, and so it's just a degree of protection you're going to be getting from UV light, and it's thought that anything above 30 is going to provide adequate protection, at least for a certain amount of time. So it's also important to weigh how long you're out in the sun and what you're doing in the sun. So if you're swimming or perspiring a lot, that may wear off sooner. So you'd want to make sure to follow instructions to reapply, as instructed on the label.
And then there are some sunscreens that will say, the ingredients will be listed. So for example, it'll say something like zinc oxide or something like that. I mean, is one better than the other, or do we just look at the SPF and buy whatever's on sale or smells better?
Right. I think generally the SPF and the broad spectrum protection are the most important factors. I don't really have an opinion on some of the specific ingredients. Some people may differ, but I think as long as you're getting that adequate SPF and the broad spectrum coverage, that's usually fine from what you'll be able to find available to purchase.
Okay, perfect. So that takes care of kind of sun exposure. But I heard that melanoma can also occur on places that aren't sun exposed, like your eyes and under your nails and the soles of your feet, even if your feet are covered with shoes. Can you talk a little bit about who gets those kinds of melanomas and whether there's anything we can do to prevent those?
Right. That's a really good point. And I think that's something that most people, in my experience, are not aware of. And really, it's the people who see and treat melanoma who are in the oncology field that are most aware of that. And so certainly cutaneous or skin melanomas are the most common, and they're related to, as I mentioned, the UV light exposure. But there are other varieties, and they can happen in a few places. So as you said, the soles of the feet, the palms of the hand, under the nails, that's one class. It's a subclass of skin melanoma, but it's thought to be different. It's not really related to sun exposure, UV exposure, and so it behaves a little differently. And then there's another broad class that can occur on mucosal surfaces, and that's also not related to UV exposure. And then there's, as you said, melanoma can develop in the eye, and all these are thought to behave a little differently. So sun protection isn't really going to prevent these or shape the development of these nearly as much or at all compared to skin melanoma or cutaneous melanoma. So what can people do about that? I think we encourage people to do self skin checks regularly. Once a month is a common time frame, and that includes checking the palms of your hands and soles of your feet and under the nail beds. And so that will, if you see anything that's not related to an injury, something that wasn't there before, something that's growing or changing, we encourage you to contact your healthcare provider and discuss it with them, and they'll determine, if it's something that needs to be examined further. And then if it's just general good health advice. If something new's going on, you don't feel right, something's going on with your body, and you just think something's going on, we encourage you again to talk with your healthcare provider and have them help you evaluate what needs to be done about it.
Yeah. And so that brings us to when we talk about doing those regular skin checks, the ABCDEs of melanoma. Can you remind our audience as to what those are? Sure.
No, I'd love to. And I think those it's a nice mnemonic to help remember what to be looking out for. So A stands for asymmetry, so that if something doesn't look even from one side to the other. B is the border, so if there's an irregular border. C is the color, so if things aren't even, if they're different shades of brown or just multiple different colors, that's something to look out for. D is diameter, and there's some size cutoffs, but a good rule of thumb is bigger than a pencil eraser is something to really start monitoring or have checked out. And then E is evolution, or how things are changing over time. So those are all guides to help people remember. If you see or notice any of these factors in a lesion you have on your skin, that's a good time to bring it up with your healthcare provider and have them determine if more needs to be done.
And so let's say you do see something that's, changing and it looks kind of odd and it's got variegated colors. It's starting to become bigger than a pencil eraser and it's certainly asymmetric. And you call up your doctor with some trepidation, because I find that a lot of people don't particularly enjoy going to see the doctor. But what can you expect in terms of what your doctor will do in terms of the workup for melanoma?
Sure. So usually your doctor will bring you in to have a look themselves, or possibly have you send a picture. But typically, I think you'd come in person, and your doctor would inspect and also give it their own assessment of it. But typically the next step, if those factors are present, is to have a biopsy done. And what does that mean? That's a little sample taken, and that's typically done by a dermatologist. So if you are going directly to your dermatologist, then it's a one-step process if needed. But if it's your primary care doctor, typically they would then send you to either dermatologist you have or set you up with a new dermatologist who will then also do an evaluation and assessment, and if needed, do a biopsy. And the purpose of that is to get a sample and to look under a microscope and perform pathology and have trained experts look and see what this truly is, if it's just a typical mole or a precursor to melanoma or actual malignant melanoma. And so that's how the diagnosis is made.
And so, one of the nice things about finding things early when they're precursors to things is that they're generally well treated. So can you talk a little bit about how frequent it is to find melanoma in that precursor stage? And is it true that, that can be very well treated? And how exactly is that treated? And if you get that, does that mean that you're cured?
So yeah, that's a really good set of questions. So I think the precursor melanoma is pretty prevalent, probably about at the same rate as we find more invasive melanomas. And generally, it's treated with removal, so a surgery either if the biopsy gets it all, or a little wider removal if needed to remove it. And if there are no signs of remaining melanoma, then patients are generally watched for recurrence or see if the melanoma comes back in a different way really closely. If needed, certain topical creams can be used in some instances to help also help prevent recurrence or to help remove some of it if surgery is no longer the best option. But generally, those are treated with removal surgically or by a biopsy, and then just watch closely. And I think cure rates are pretty good. So as you mentioned, the earlier things are caught, the better the long-term outcomes.
And so let's suppose you're not so lucky and you happen to get a melanoma that is an invasive melanoma. You had mentioned earlier that there are different kinds of melanoma. Can you talk a little bit about which kinds of skin melanoma are the most common, which are the worst in terms of prognosis? Kind of give us a landscape of what melanoma looks like. Sure.
I'd love to. So melanoma, of the skin or cutaneous melanoma is just another name for it. Even within the more common skin melanomas, there are different subtypes based on tumor profiling. So we look at specific genetic changes in the tumor, and that depending on how advanced it is, and that gives different. Has different prognostic implications and different treatment options. But then there's ones that occur on the like we mentioned the soles of the feet or the palms of the hands or under the nails, and those generally are not as responsive to the typical treatments we use, which we can talk about more a little later. So we know that we still possibly use them, but we know they might not be as responsive to them. And it's just based on their nature not being as related to sun exposure, which makes certain skin melanomas more susceptible to the types of therapies we use, which are called immunotherapies, which activate the immune system.
Fantastic. Well, we're going to take a short break for a medical minute. Please stay tuned to learn more about the care of patients with skin cancer with my guest, Dr. David Schoenfeld.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their screening and prevention program recommends that everyone perform monthly head-to-toe self-examination of their skin and protect themselves from the sun year-round. SmiloCancerHospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and at Smilow Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Smilow Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. David Schoenfeld. We're talking about the care of patients with skin cancer and particularly melanoma. So before the break, we were talking about the fact that melanoma is not the most common kind of skin cancer, but probably one of the most deadly. And we were talking about the fact that we can really look for changes in the appearance of moles or other lesions on our skin and go get those checked out, because a biopsy can often give us the diagnosis. Now, David, you had mentioned that about half of these can be found when they're pre-invasive, which is great, very treatable. But it seems like if melanoma is one of the most deadly cancers, that the other half that are invasive really have a worse prognosis. So can you walk us through, how does the diagnosis get made after the biopsy? So in terms of staging, and then what can patients expect in terms of treatment?
There is, even after you have a diagnosis of invasive or malignant melanoma, not just a precursor, there's still a wide variety of paths that patients go down. And a lot of it is based on, there's a whole bunch of what we call prognostic factors, so factors that predict how risky a melanoma is from coming back. And the big one of the biggest ones, is the depth. So unlike other cancers, it's not really melanoma. The risk of melanoma is not judged based on how it looks on the surface, how wide it is, but it's more its depth of invasion into the lower layers of the skin. So typically after a diagnosis, most patients, not every patient, the really, really shallow depth melanomas may not need this, but most patients will then go for a surgery with either a plastic surgeon or another type of surgical oncologist or another type of surgeon who will do something called a wide local excision, possibly with a sentinel lymph node biopsy. That's checking to see if the melanoma spread to the local lymph nodes. And so that's considered the next step and one of the main treatments, especially for the less invasive, so the melanomas that don't go as deep. So that's typically the next step that follows in the treatment process.
Terrific. So can you tell us more about that?
Yeah, I'd love to. So after patients have the biopsy, then they're usually referred to, and let's say a diagnosis of melanoma is made. They usually then go see a surgeon. And so we have a team of surgeons we work with very closely who we're constantly in communication with. But that's usually the next step. And then they go for their surgery. And the surgery, the real point of that is to make sure we're getting all of the melanoma and to get as clear an area around it as we can. And we know that has a real benefit to helping prevent the melanoma from coming back. So that's a really key step. And that is the extent that almost all patients will undergo next.
So we found it with a biopsy. We've kind of looked at staging. They then go on to have surgery. You had mentioned before the break that you really are looking at mutations of these cancers. And when we talk about mutations, we often think about personalized medicine and how we can tailor therapy after surgery, usually, in terms of, which drugs a particular patient may need. Is that the case in melanoma as well? And do all patients need some sort of systemic therapy, or is that individualized too?
You're exactly right. So it's very individualized. So some patients may not need any further therapy after they have the surgery. They will just need to be followed closely, and that's something called what we call active surveillance, and that can depend on what the risk is of the melanoma coming back. So the less risky melanomas or the least risky melanomas, there's no role used typically for looking at these mutations to check for them. There's no role for what's systemic imaging to do CAT scans, let's say, of the body to look. And they might only need to see myself or another healthcare provider once a year just to check in is typically our recommendation for the lowest stage melanomas, make sure everything's going well. And they'll certainly also see their dermatologist for skin checks, usually at least twice a year. But if people have more invasive melanoma, so melanoma that goes deeper, that's riskier, then there could be a role. So a lot of these drugs have been studied, and depending on the risk factors, there could be a role for targeted therapy. So therapy that's based on certain mutations. So for the highest risk or the higher risk melanomas that haven't spread beyond the local site, there is a role for giving targeted therapy to help prevent the recurrence of the melanoma. But that's only done if a certain mutation is present. So in those cases, we'll talk about it with the patient and describe the reasoning. And if they meet their criteria, we'll offer it. And then if that certain mutation is present, there'll be a candidate to get this sort of therapy to help prevent the recurrence from coming back.
And so what is that mutation, and what is the medication that you give? And does it have a lot of side effects? And if you don't have that mutation, but you've got a high-risk melanoma, does that mean that you don't get anything, or is there a not so targeted option for those patients?
Right. So the most common mutation in skin melanoma and cutaneous melanoma, and the one we're really looking for at this stage, is called BRAF, so BRAF. And that's a certain protein that's found in cells that can be mutated at a high rate in skin melanoma. And we know that. And the rate is about 50% for your typical cutaneous melanoma. And if you have the most common types of mutations in that gene, we know that certain pathways are activated in your melanoma. And then there's a set of 2 drugs, and there's a few different varieties, but they all target the same pathways. And so they're called BRAF inhibitors and MEK inhibitors. And there's a few companies that have a set of drugs that inhibit those, but we know that they're effective if you have that mutation, if you have the right mutation. So in those cases, then we would offer those sets of drugs for 1 year to help reduce the risk of the melanoma coming back. And I think for some people, again, they do well with those drugs and don't have any side effects, but often patients experience some side effects, most commonly being fatigue. They could develop a rash. They can develop joint pains, and there can be some GI side effects, and that means some change in appetite, nausea or vomiting or diarrhea. And we do our best to control those, to minimize those as much as possible. Some people need to have reduced doses of the drugs or even take breaks, or sometimes can't even tolerate the drugs. And then we just watch things very closely. The good thing about those drugs is that once you stop them, the side effects typically go away pretty quickly, or nearly all cases go away. Now, your next question about what to do if people don't have that mutation, well, there are other options, and that is a large fraction of our patients. So for those patients, again, who have the riskier melanomas, there is an option of receiving what's called immunotherapy, and I mentioned that before, and that's a class of medications that you can think of it as taking the brake off the immune system, so allowing your body's own immune system to go after the melanoma or to any remaining melanoma cells, in this case, that might be present. And that's something that's used pretty extensively in melanoma, especially in melanoma that's spread, so that's become stage 4 metastatic. But we also use it in this earlier stage to help prevent the recurrence. And it's also pretty effective there, and we treat for a year, and we treat a lot of patients with that sort of treatment as well.
Fantastic. And then usually when we talk about cancer, we think of a trifecta of surgery, systemic therapy, and radiation. But when we think about melanoma, with what you said before the break, with it being caused by UV radiation, one would think that radiation wouldn't be used very much in melanoma. Is that right?
I think that's right in general. It's not used as much as in other cancers. There are still situations in which it can be used. depending on the circumstance, especially in let's say the metastatic or stage 4 setting, in certain situations when there's an aberrant lesion or a lesion that's not responding as others, or a single focus, that could be more of an option there. Sometimes it is used to help prevent the recurrence in certain sites of a melanoma, depending on some factors of the specific melanoma. But you're right, it's not typically used, and it's not really thought to be because it's going to lead to more melanoma. It's just not as effective as in other types of cancer.
Okay. So now that we've kind of walked through how melanoma might be treated, how effective is the treatment? Because you had mentioned before the break that melanoma is still one of the most deadly cancers. So what can people expect in terms of their survival?
So I'd like to also clarify that I think melanoma is among the skin cancers one of the most deadly, but it really has undergone a sea change in how it's treated. And if you look at melanoma from 15 years ago, the treatment's totally different, and the treatments are much more effective than they were. Melanoma was a very, very tough type of cancer to treat for the longest time. It's not typically or not very responsive to chemotherapy, with very low response rates. And it was very difficult to treat people who had stage 4 melanoma. But that's really changed now, I think, because of the types of medications I mentioned, especially the immunotherapy. And melanoma is the type of cancer that's most responsive to this class of medications, to immunotherapy. It's where it's been approved for the longest and most widely studied and used, I would say. And it relates to how melanoma comes about because of the UV ray exposure, which causes a lot of mutations. And we know that cancers that have a lot of mutations in general are more responsive to this type of therapy. And so melanoma is generally, if it's spread, treated for patients that can receive it with immunotherapy, and it's very effective. We think it can offer high response rates and give people a chance for a very long-term response. And so if we're thinking of a typical skin melanoma, cutaneous melanoma, 50% or more can have a really good sustained response. So I think it's really revolutionized our treatment of melanoma.
Fantastic. You had mentioned at the top of the show that you're actually very involved in research, both in preclinical kind of work in your lab, as well as in clinical trials. Can you talk a little bit about what you think is exciting on the horizon for the treatment of patients with melanoma, and a bit about what you're working on?
Sure, I'd love to. So I think, as I mentioned, the immunotherapy can be very effective, but we still know there's a large proportion of patients who eventually will stop responding to our existing forms of immunotherapy. So a lot more needs to be done, and I think there's some very exciting work being done. Also in the same field, looking at agents or factors that could alter the body's, a patient's own immune system to help it go after the cancer. So if we think of classic immunotherapy that we use now as taking the brakes off of the immune system, I think some of the more exciting research being done right now is the flip side of that. So you can think of it as putting your foot on the accelerator of the immune system. So activating a patient's own immune system, and these are through drugs such as modified cytokines. So cytokines are naturally occurring chemical messengers in people's body. And so now a slew of agents are available that we're testing and that I study in the lab, and that of course are being widely studied, that are hopefully going to be more effective than that have been modified to hopefully make them more effective and have less side effects. So I think that's one very exciting field. And there's a whole bunch of other fields, something called cell therapy. So you're taking out cells from the body and putting them back in, either with a modification or just activating them. And also using personalized cancer vaccines as a way to prevent the recurrence. All these are very exciting and very promising.
Dr. David Schoenfeld is an instructor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.